get it. This color scheme has been changed. Okay. So we've covered a lot of this before, but I again want to bring it up and highlight some really important things here. Okay. I don't know what just happened. I don't know why I didn't touch anything, and there's one of you like magically controlling the lecture and making it go forward. Cardiovascular disease is the leading cause of death in the U.S. and worldwide. Okay, so if there's one thing that we can try to use exercise to have some positive outcomes from, then it's going to be how we target cardiovascular disease. Okay, in some way, shape, or form, we can attribute nearly 40% of all deaths to cardiovascular disease. Okay, as you all will see tomorrow, if I'm a type 2 diabetic, there's a very, 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 very strong chance that I'm also going to have multiple types of cardiovascular disease. So those things are what we call comorbid. They exist together. And so this is the single biggest health problem associated with obesity and being sedentary in the world. Okay. So we're going to talk about different forms of cardiovascular disease. Okay, and so when we look at it as it relates to kind of the causes of death, about half of all cardiovascular disease related deaths are going to occur from something called coronary heart disease or coronary artery disease. And we will get into the pathology of this, but it's a disease that's going to affect the arteries that bring blood from the heart back to the heart. Okay. And so when that blood flow becomes impaired, then it causes all kinds of problems with cardiac conduction in the heart, and you're going to get arrhythmias, and it also can lead to the death of some of your cardiac muscle, which makes the heart weaker. And kind of the collective effects of all of that are that you cannot circulate blood properly. Okay. Strokes, you guys will see strokes are going to be disruptions in blood flow to the brain. We'll see what's called hypertensive disease. So high blood pressure, as you guys will see, is very, very common in people over the age of 60. Very rarely does the high blood pressure itself actually kill you, but having the high blood pressure is going to dramatically exacerbate and lead to coronary artery disease, and it's going to exacerbate or cause, kind of more strokes to happen. Okay. And it's going to play a role in what we call congestive heart failure, where the heart cannot beat forcefully enough to be able to circulate blood around the body. So basically, you're unable to move blood. So in the U.S. every year, there is somewhere north of about 1 million heart attacks that are going to occur. So this is a huge thing because there are so many heart attacks. We have a new standard of care where we're gonna get people up and do cardiac rehab almost immediately when they're inpatients, and then even right when they're outpatients after they're done. So we use exercise as a treatment for people that are post heart attack. So exercise and physical activity, as you will see, will play this dramatically large role in both preventing the progression of the pathology, so it can prevent the development of these types of cardiovascular disease. But then once you have it, and maybe you've had a heart attack or you have some form of this disease, you can also use exercise and physical activity to slow the progression of the disease or to potentially use it as a treatment for recovery from everything. Okay, and we'll get into kind of the hows and the whys of all of that in the coming slides. Okay, so we're going to cover 4 main types of cardiovascular pathologies. Okay, as I said, we're going to talk about coronary artery disease. We're going to talk specifically about a heart attack, so having a myocardial infarction, which is typically accompanied by something called angina pectoris, which is just this projecting pain that's associated with the lack of blood flow to the heart. We'll talk about strokes, okay? And then we'll talk about high blood pressure. Now, there are a couple of other forms. There's something called congestive heart failure. There's something called peripheral vascular disease. They're a little bit less common, but they're actually going to look a lot like these other kinds. So we'll just mention those very, very briefly. Okay. At this point in the lecture, we need to make a distinction. This distinction is really important. And so what you guys may be wondering, what everybody kind of hears about, is a process called atherosclerosis. Okay. And so atherosclerosis is a condition that is going to underlie all of our different, for the most part, all of our different kinds of cardiovascular morbidities, all of our different types of cardiovascular disease. Okay. Atherosclerosis is a process and in some ways a condition. It is not in and of itself a type of cardiovascular disease. Okay. So it may be the thing that is going on that is going to cause these things, but it is not. Okay. You have to have atherosclerosis in order to develop coronary artery disease. Okay. So sometimes there's a little bit of confusion in the literature and in the popular press. Okay. But it's a process and the underlying condition. Okay. And we're going to talk about what that process looks like. We're going to talk about why it's so important and why it's going to underlie all of the other kinds of things that are going on. And hopefully that will make you guys understand why high levels of LDL cholesterol, high levels of total cholesterol is one of our risk factors for cardiovascular disease. Okay. Everybody okay so far? Anybody have any questions about these kinds of things? No? Okay. All right. So to understand the types of cardiovascular disease, we need to first understand this underlying condition that is atherosclerosis. So atherosclerosis is going to describe the process of the development of these fatty plaques, okay, that are going to form on the inside of arteries and arterioles. And as this progresses, okay, these plaques are going to get thicker and thicker. As they become thicker and thicker, you will note that the inside diameter of an artery and an arteriole is going to get smaller and smaller and smaller. That narrowing of the diameter due to atherosclerosis is going to lead to a couple of things happening in the blood flow response through those vessels. Okay. The first thing that happens is as we narrow the diameter, okay, much like as we controlled where blood was going by vasoconstricting and vasoconstricting and vasodilation with the smooth muscle, is as that artery narrows, less blood is going to be able to get through it. Okay. So atherosclerosis is going to make it more difficult to get blood through those arteries to the tissues that are going to be distal to them. All right, so you can imagine if I have atherosclerosis in, say, the coronary arteries, then it's going to make it more difficult to get blood to the heart. If I have atherosclerosis in my cerebral arteries and the arteries that are going to lead to the brain, then it's going to make it, there's going to be less blood flow that's going to go to the brain. Okay, so in that way, that can lead to some of the issues that we see with coronary artery disease and lead to some of the underlying things that are going to happen when the person has a stroke. Okay. The second thing that happens in response to atherosclerosis is the pressure of the blood moving through those arteries is going to increase. It's just like if you can imagine shooting water through a water hose, right? When you want to shoot your friend, or when my daughter wants to shoot the water hose at me, you have the water hose, right? And you put your thumb or you put your finger over the edge of the water hose, you are narrowing down the area that the water has to come out of the hose. That raises the pressure, okay, because the area has, or the diameter has been narrowed. It raises the pressure. And that's why when you put your thumb over the water hose, it shoots the water out faster. It goes farther. Well, the same thing happens here. It's going to raise blood pressure of the blood moving through there. Okay. Raising the blood pressure is not always a terrible thing. Okay. If you raise the pressure, then you're going to be able to move more blood in theory to whatever is downstream of it. But the big issue is that some atherosclerosis is going to lead to this condition of hypertension that we experience. Okay. And there are some issues when, like, your resting blood pressure is chronically elevated that can cause some problems for the heart, for the blood vessels, as you guys will see. It can also lead to some blood clotting problems. It can lead to sort of bursting of blood vessels, at aneurysms and those things. Okay, so having atherosclerosis, it can reduce blood flow and it increases blood pressure. So that's the two primary things that it does that are going to be bad, okay, that are going to be bad. And for almost all of our cardiovascular diseases, those two things, reduced flow, increased pressure, are going to be part of the underlying pathology. All right? All right, so how does this happen? Okay? I hate to break it to you guys, but every one of you has some level of atherosclerosis, in especially the high pressure arteries in your body right now. All of you probably have some level of atherosclerosis, hopefully very little, in your carotid arteries, okay? Probably in your coronary arteries and maybe a little bit in your cerebral arteries, right? So how and why does this happen? Now, atherosclerosis is a process that takes years to happen. This takes years to happen, okay? It tends to occur most often in arteries and arterioles, particularly in arteries, because it's going to happen in areas that are going to have the highest amount of blood pressure normally, in high pressure areas and in areas where there's a lot of blood flow moving through. Okay, and you'll see why that's going to be the case here in the next couple of minutes. Okay, so it tends to affect arteries that are closer to the heart and ones where there's a lot of flow and a lot of pressure. So carotids, coronaries, okay, are the primary ones where we're going to see a lot of this. So the initial event in the development of atherosclerosis is going to be an injury to, or an insult to, the inner lining of an artery. So the inner layer of cells that you can see right here, okay, the inner layer of cells is called the vascular endothelium, okay, the vascular endothelium. It's a single layer of cells that lines all of your arteries. The endothelium is really, really important for regulation of blood flow and regulation of blood pressure, because the endothelium can release a substance called nitric oxide, not nitrous oxide, not laughing gas, but nitric oxide. So it's just NO. And the endothelium, when it releases this nitric oxide, that causes blood vessels to vasodilate, and it will lower the pressure in those vessels and slow down blood flow through. And so, as you guys will see, when you develop atherosclerosis, the plaques are going to cover up the endothelium, and so those blood vessels can't regulate blood pressure nearly as well. And so you're going to get an exaggerated blood pressure response, which is going to be bad. But the development of this is you get blood flowing at high pressure very fast through these arteries, okay? Your blood is water, but it's also all of these different cells and then all of the other molecules that are going to be in there. And so what will happen is you're going to get these little small nicks at times in the endothelium, or you're going to get damage in there caused by what are called reactive oxygen species, which are also going to be these kind of negative affecting types of molecules that we could spend 2 weeks talking about the biochemistry. But you're going to have some of these things. If you eat a lot of LDL stuff, you're also going to have a lot of reactive oxygen species. So you get a little nick and a little bit of damage. Okay. Like every other tissue, when you damage a blood vessel, your immune system is going to mount a response, and it's going to try to come in and repair and fix the damage. Okay? And so what happens then is that you're going to get infiltration of white blood cells, which are called some of them are called macrophages. This infiltration of white blood cells, okay? And you're very often at these nick areas, you're going to get LDL cholesterol stuck in the nick, right? And so it's going to get in there. You're going to get the LDL stuck, and then you're going to get these macrophages that are going to come and try to eat up the LDL and start releasing a bunch of different things, okay? Then that's going to lead to the formation of something called a foam cell, which is basically a macrophage that has tried to eat up a bunch of LDL and it can't do it all the way. So it creates these foam cells, which are going to be this intermediate lesion that you're going to be able to see right here. And so what's going to happen then, though, is that the macrophage and the LDL are going to start to kind of infiltrate their way into the endothelial lining. And so what's going to happen then is they're going to start pushing out of the way regular functioning endothelial cells. Okay? That's going to continue over time, right? That's going to continue over time where you're going to get more and more LDL accumulation. You're going to get more macrophages. You're actually going to get some platelets and things that are going to come in there. And that's going to form something called an atheroma, all right? And so when you're going to get this atheroma, you're going to start putting more and more LDL in as it accumulates all of these things, and it just gets sort of shoved in, right? Shoved in kind of with the endothelial cells, and then it begins to pile up on top of them, that there just becomes more and more LDL accumulation. The macrophages begin to digest all of those things. The LDL gets stuck in there. Some platelets begin to kind of aggregate on top of it. And then at some point in the midst of all of that, you're going to just start kind of piling more and more of this on top, and it's going to begin to push up and narrow down the artery. Okay? And so then it becomes what's called a fibroatheroma, and we're going to begin to put this fibrous cap, right? So it says, we can't fix this, we can't get rid of it. Let's just put some very inflexible fibrous tissue on top of it and just try to seal it off from everything else. And then eventually, though, you're going to get more and more of those things piling up on top of each other, and it's going to look like this, which is called a complicated lesion, and those kinds of things. Okay? I'm not going to ask you any questions about the exact etiology of the development of atherosclerosis. You're not going to have to know the difference between an atheroma and a fibroatheroma or anything, but I do like to talk our way through it so you guys can begin to understand. Okay, this is a process that is going to take years and years and years to happen, right? It will typically begin maybe in people's early teenage years, depending upon your activity levels, depending upon what your diet composition and things are going to be, depending upon if you have a genetic predisposition, right? But it may take 30, 40, 50 years before you're going to develop a large enough lesion and a large enough deposit of these fatty plaques here before it narrows those arteries enough that you're going to have some sort of noticeable problem with pressure and flow through those vessels. Okay? This is one of the reasons that if we look at the prevalence of cardiovascular disease, okay, especially coronary artery disease, especially hypertension, okay, and especially strokes, it tends to be much more common in people that are most of the time over the age of 50, because it takes a long time for this to develop. Okay, so while all of you may have a little bit of this, most of you are not going to have any kind of appreciable clinically relevant amount. I probably have more than all of you guys, especially given my love of Doritos and chicken fingers, but you know, I probably still am not going to be in a place where it's quite that bad yet. I do have a fair amount of family history with all of this. Again, this is one of the reasons that I try to exercise as much as I possibly can, because as we'll see, exercise can function to prevent the deposition of these fatty plaques. Okay. Anybody have questions about all of that? Do you all talk about how all of this process works in like human phys or anything?
Not that I remember, at least not this detailed.
Not that detailed. Okay. Okay. Well, and I don't know what they've done. I don't know what page changed. If you take the chronic disease course, I know she changed and made it a little more epidemiology based and a little less physiology based. I don't know how that's going to go now that Paige is leaving into something else, but we do talk about it in quite a bit of detail in the chronic disease class as well. So if you're interested, there's a lot of things that are going on there. All right, so let's assume that maybe you're a 65-year-old person and you have developed a relatively large amount of atherosclerosis in, say, your coronary arteries. Okay. Your coronary arteries are particularly susceptible to atherosclerosis. Okay. This is because they're so close to the heart that they're going to have a relatively high pressure through them, and because you need so much blood going to the heart that they're also going to be very, very highly branched. And so one of the things that happens is that atherosclerosis tends to develop near bifurcations in arteries. So where one artery splits off into two. Because what happens is at that bifurcation, you're going to get some blood that's going to be driven left, some blood that's going to be driven right, and some that's going to keep going down the middle, and it's going to hit at the kind of the median point there, and it's going to cause lots of turbulence in the flow there. And so because of that turbulence, you're going to get lots of extra friction on the vessel walls there. When that's done at high pressure, think of blood. Anybody ever used a pressure washer? Anybody ever are familiar with the idea of a pressure washer, right? And so you take the pressure washer and you hose off your deck or something with it, and it's just using water at high pressure to blast things out of the way. And so imagine that rather than even doing water, we had our neighbors, they had some guys come 2 weekends ago, and they'd put a bunch of silicone beads in the water, and they were in essence sandblasting or particulate blasting paint and rust and things off of this our neighbors have a 67 Mustang, and you can use water, and then water with a little bit of particulate matter in there will strip paint and stuff off of cars. Think of your blood is water with particulate matter in there. So if the pressure is high enough, it can generate a lot of friction. And at those bifurcations, that friction is going to be a little bit higher. So high pressure, lots of bifurcations, that makes the coronary arteries particularly susceptible. So you've got this atherosclerotic plaques that are going to begin to develop in your coronary arteries. Okay? What that does then is it raises the pressure of the blood going through there, which is just going to exacerbate in some ways the development of more atherosclerosis, and it's going to potentially reduce the amount of blood that can flow through those coronary arteries, which means that there's going to be cardiac muscle that may not receive as much oxygenated blood as it normally needs. Okay? What happens then is something called ischemic damage to the heart. So ischemia means a lack of oxygen. So when you have ischemic damage to the cardiac tissue, what that means is that there's muscle that's not getting enough oxygen, and you're going to have cardiac muscle fibers that are going to die. Okay? They're going to die. And that's what's denoted here, okay, in the kind of darker red area. Because we have these plaques, we're not getting enough blood flow through here, and so that cardiac muscle dies. When that cardiac muscle dies, a couple of things can happen, okay? One, it's like having atrophy in any muscle in your body. Then if that is whatever atria or ventricle that muscle is a part of is now not going to be able to contract as forcefully. So that may reduce stroke volume. Okay, it may reduce the amount of blood that can be moved through there. Okay, if we reduce stroke volume, it may lead to compensation to maintain cardiac output, that heart rate has to go up, or it may be sufficient that overall cardiac output is going to decline, which is going to be bad then for our exercise capacity. Additionally, though, when you get ischemia in certain areas, when you get tissue death in those areas, that may also disrupt the ability of the cardiac conduction system to transmit the necessary electrical signals along the heart and through the SA node, the AV node, the bundle of His, and the Purkinje fibers. And so you may get what are called cardiac arrhythmias. So when we disrupt normal cardiac rhythm, okay, then you can get irregular heartbeats. You can get the atria and the ventricles contracting simultaneously, which will mean then that no blood is going to move anywhere. You may get blockage of those signals, and so that particular chamber may not contract when it's supposed to. So when you have these arrhythmias, the arrhythmias are going to potentially cause the heart attacks. Okay? Does that make sense, everyone? You kind of see how the progression of you get the atherosclerosis, it causes reduced flow and it raises pressure. The reductions in flow can cause tissue death and potentially these problems in cardiac conduction. And so then that's going to have, even if your conduction stays the same, you're going to have a weaker heart, and that's going to be potentially a problem over time, and or it may cause an actual myocardial infarct when you disrupt the conduction. Okay. All right. So I mentioned this already, but I always find this picture to be very spectacular. So what you see down here, and again, you don't have to, I'm not going to ask you guys any anatomy about like which coronary artery is going to bring the most blood flow to the distal portion of the right ventricle or anything else. But I am always just sort of really taken with this picture here where they have injected red and blue dye into the blood vessels. So the arteries are going to be stained red and the veins are going to be stained blue. And then they've dissolved all of the cardiac tissue around all of this. And so you can see here all of the coronary arteries and the coronary, probably some of those are going to be coronary arterioles that are going to connect to the heart. So the heart is an amazingly vascular tissue. And so you can imagine that if I was to get significant atherosclerosis, especially up in one of the kind of larger feed arteries, right, that's going to connect to all of these kind of smaller downstream arteries and arterioles, I can really have impairment in blood flow to a large portion of my cardiac muscle. Okay. And so when people talk about getting bypass surgery or having coronary stents or something placed in there, what they're talking about is trying to fix or kind of circumnavigate blockages in flow through some of these kind of large arteries. And we'll talk a little bit more about the treatments for that in a couple of slides. Okay. So here's a coronary angiograph. Here's a person that has sort of normal flow through all of these things. They've injected dye. And so when you take this fancy x-ray with the dye, what you can see is here's the outline of the heart there, and you're seeing blood flowing through some of our larger coronary arteries here. The one on the right, this is a person that has 95% narrowing due to atherosclerosis, okay, in their left descending coronary artery. So what you can see right here. And so what's happened in this place is what you see that's going to stain is the blood. The blood moving through causes that dark shading. And so it's not that the vessel in and of itself has gotten smaller at this place. It's just that there's this markedly reduced amount of blood that's getting through there. So it makes so that the hole in the vessel, the lumen of the vessel where the blood can go, is much, much narrower. And so you can see then we're only getting 5% of normal flow through there. That person, if they're doing anything like that's barely above rest, is going to have noticeable issues that are going to go on because they can get almost no blood flow through their left descending artery. Okay. All right. So that's kind of what it looks like. So let's talk about the things that are going to be risk factors. They're going to put you more at risk for developing coronary artery disease or developing atherosclerosis that's going to cause coronary artery disease. The primary ones should look very, very, very familiar. Okay? Smoking, high blood pressure, high blood lipids, so high LDL, high total cholesterol. We've not really talked about blood triglycerides, but if you have high triglycerides, that's also going to put you at a greater risk. Okay? High blood pressure, you've got higher pressure flowing through, that can cause more damage. If you have high LDL cholesterol, there's more lipid that has a chance to get deposited into any of those little nicks that are going to be placed in the vessels. Physical inactivity is a huge risk factor for this, as is obesity. Okay, and so obesity is often associated with these high LDL levels. Obesity is associated with a high production of reactive oxygen species, which are going to lead to larger development of those things as well. Secondary risk factors are diabetes, a family history of coronary artery disease or a family history of atherosclerosis, being a male, and then advanced age. Okay. Do the things listed on this slide look familiar to you? Where might we have seen these very recently?
The pre-exercise assessments.
Very good, Preston. These are the risk factors that we're going to ask people about on the pre-exercise screening form. Okay. So this is why those things are on there. These are the things that put you at greater risk of coronary artery disease, and having coronary artery disease is the single largest predictor of a person that's going to have a heart attack or some kind of arrhythmia during a bout of exercise. Okay, so that's why we're going to ask about those things. It all kind of fits together, if you will. Okay. All right. So who is or why are some of these things? I want you guys to look at all of this. Okay. This is the percentage of the U.S. population that is at risk for or at an increased risk for developing coronary artery disease based upon each individual risk factor. Okay. So if you look at this, all right, people that have hypertension, people that have elevated blood pressure, okay, if your systolic pressure is, let's say, 150 millimeters of mercury versus a person that is at 130, okay, then you're about 2 times as likely to develop coronary artery disease. That's going to affect about 10% of the U.S. population. About 10% of the U.S. population has a systolic pressure that's greater than 150. If you have elevated serum cholesterol levels, okay, if you're a person that's at 268 versus you're a person that's still high at 218, but if you're that much higher, that you have about 2.5 times the risk of coronary artery disease, that also affects about 10% of the population. If you smoke, smoking may be the single thing that is the biggest effect on developing atherosclerosis and coronary artery disease. 1 pack per day of smoking versus not smoking at all is about 2.5 times the risk. Okay, that affects almost 20% of the population. But look at this one. If you are physically inactive, okay, physically inactive, versus someone that is just getting 20 minutes 3 times per week of like moderate to vigorous activity. Okay, not even that much. Just go walk briskly for 60 minutes a week. We're not even really meeting our guidelines. You're twice as likely, okay, to develop coronary artery disease. 60% of the US population is going to be affected by that, okay? 60% aren't getting, that much activity, okay? So you're twice as likely to develop this if you coronary artery disease if you are inactive, okay? So that's why exercise has this very, very powerful effect on preventing the development of atherosclerosis and preventing the development, therefore, of coronary artery disease. If you can stay active throughout your life, okay, you can really, really reduce your risk of developing cardiovascular diseases, especially coronary artery disease. I cannot begin to emphasize this enough, okay? I cannot begin to emphasize this enough. Okay, so which of our risk factors are going to be positively affected? And this is why exercise is so effective, okay? Of those risk factors that we were screening for yesterday, these are the ACSM risk factors that we screen for. Being just moderately active has positive impacts on 5 of the 7, okay? It doesn't do anything about family history, and it doesn't do anything about smoking directly, but we'll talk about the effects of exercise and smoking in just a minute, okay? If being sedentary itself is a big risk factor, if you're active, you can remove that one, okay? Having impaired or elevated fasting glucose levels is a risk factor because diabetes is a secondary risk factor for the development of coronary artery disease. If you meet the exercise guidelines or you meet the physical activity guidelines, right, you're going to have, again, this dramatic reduction in your chances of having impaired fasting glucose, regardless of, sort of obesity levels. People that exercise are going to have lower LDL cholesterol and lower total cholesterol levels than people that are sedentary, okay? People that are more active are also going to have significantly less chance of becoming hypertensive. Exercise lowers blood pressure. If you are a person that is hypertensive, exercise can lower your blood pressure. If you're a person that has high LDL and high cholesterol levels, don't change your diet, don't do anything else, just start exercising and your LDL and total cholesterol levels go down, okay? And then, although it is not necessarily the best way to reduce obesity, okay, exercise can be a way to lower obesity rates, okay? It can be a way to lower obesity rates because of its very powerful effects on fasting glucose, LDL cholesterol levels, and hypertension. Even if you are obese, and even if you exercise and you remain obese, right? Remember our things. If I'm fit or I'm active and I'm obese, I'm in many ways better off than a person that is sedentary but normal weight, okay? So 5 of our 7 risk factors can be positively affected by exercise or by being more physically active. Smoking is not on there, okay? But we do see some interesting things whereby people that tend to be more active will very often be kind of less risk of being smokers. Okay, it's not that exercise, even if you do smoke, it's not that exercise can counteract some of the negative effects of smoking. It's mostly just that people that tend to be more active and to be, exercise more tend to not smoke as often. This is one of the worries about vaping, and one of the reasons that we need to be doing a lot of studies on people that are vapors is that we don't know what the acute effects and the chronic effects of vaping are on blood vessel function. One of the reasons that smoking is so bad. So when I was a grad student, when I was doing my master's degree, like I told you guys, I worked in a lab where we measured blood vessel function, And so we would do a test on people that would determine the function of their endothelium and its ability to cause vasodilation and allow more blood flow to get through an artery and lowering the pressure through that artery so that you could basically send blood flow to working skeletal muscle during exercise and things better, which is one of the things that will happen when you start exercising. Your coronary arteries will dilate so you can get more blood flow to the heart. If you smoke 2 cigarettes, so we would have people come into the lab and they smoke cigarettes in our lab in a vent hood. Anybody's ever seen like a chemistry or a chemical vent hood? It has all this negative pressure and it sucks the air out. And they would sit there and they would smoke and then they would hold this and blow their air out this vent hood. 2 cigarettes, okay? 2 cigarettes. And we could take young, otherwise healthy, normal blood vessel function college students who were normally smokers. We could take them and we could make them look like a 70-year-old person that has severe atherosclerosis after smoking 2 cigarettes. Okay? And so but then you could counteract the effects of the cigarettes by giving them like 2 glasses of orange juice. Vitamin C powerfully counteracts some of those things. You could have them take some antioxidants and it will counteract all of that. So you can imagine one of the things that happens, people that smoke, it adversely affects the abilities of their arterioles to dilate. And so what that leads to is the development of hypertension and the development of atherosclerosis if you're chronically smoking. Okay. So smoking is very, very bad. So if the lung cancer doesn't kill you, then it's going to cause you to have coronary artery disease in the long run. And that's probably going to kill you. Okay. All right. So how and why does exercise work? Well, we're not going to get into all of the ins and outs of how exercise does things. But one of the things that it does, if you take a person that is sedentary, who's maybe 60 years old, their arteries are going to look like this one on the left. If you take a person that has been a lifelong physically active exercising person, theirs is going to look much more like this with maybe a little bit of deposits that are going to be in there. People that are more active have larger arteries, okay? Have larger arteries. So, oh God, why can I not think of the name? Angiogenesis is the development of additional sprouting of things. It's called atherogenesis, I believe. But what it does is when you exercise, your blood vessels get bigger, so they have a larger lumen. And that means there's more space that could potentially get blocked up by these plaques where you could still maintain an adequate amount of blood flow through them. Additionally, the high pressures that the blood gets to when it flows through them when you are exercising, things that raise your pressure that way. The blood also functions like a pressure washer, and it can blast off some of the development of those little plaques that are going to be in there, which may seem kind of counterintuitive. You would think that would cause more nicks in the vessels, but it can also function to blast off some of the plaques before they really, really develop in a lot of ways. So people that exercise have way better functioning and way kind of cleaner blood vessels. That's how we're going to prevent atherosclerosis and coronary artery disease. Okay. The other thing that happens, okay, is that we talked about that when you exercise, you're going to get cardiac hypertrophy. You're especially going to get left ventricular hypertrophy. And one of the things that that's going to be good for is that if the heart is stronger, and the heart has more cardiac muscle, then even if you do develop coronary artery disease, and even if you do get some tissue death due to ischemia in that part of the heart still has more muscle, had more muscle to begin with, so it's stronger to begin with. So it's going to take longer and it's going to take a larger amount of tissue damage before there can be enough weakening in the heart to kind of adversely affect stroke volume and cardiac output. Okay. Now, you can still get all of the normal arrhythmias and things that are going to go on, but that's one of the other the other things that goes on. And there's some other, the way in which you're going to get cardiac hypertrophy with exercise is also going to be advantageous, but I don't really want to talk about. There's something called eccentric cardiac hypertrophy versus concentric cardiac hypertrophy. And so people that have chronically high blood pressure but don't exercise also get cardiac hypertrophy, but their cardiac hypertrophy is very fibrous, and so the heart loses its kind of stretchiness, and it gets bigger, but it's not really stronger. Whereas people that exercise are going to get hypertrophy that's going to function to be stronger. Okay, so we've talked about some of these things, so there we go. How are we doing on time? We have talked a bunch. Okay, let's take a 4-minute break. Okay, we'll take a 4-minute break and come back at 11:50. We're recording, screen sharing. So let's talk now about angina pectoris. Let's talk about pain associated with lack of blood flow to the heart. Okay. So this is one of the primary symptoms, okay, of cardiac ischemia from coronary artery disease. So the heart in and of itself, as we've talked about in the last couple of days, does not have any pain receptors. So the heart cannot by itself let you know, like, you're not going to feel pain in your heart when there's a lack of blood flow. And so what it does is it borrows the pain fibers from kind of associated tissues. And so you will feel this radiating radiating pain, neck, jaw, left shoulder, left arm, sometimes into the back, but it's really going to be here, okay? Men very often tend to be kind of arm, shoulder. Women, for whatever reason, seem to get stuff more up into their neck, although heart attacks women are significantly reduced compared to men, okay? The pain is going to be sudden, severe, crushing, okay, kind of burning, crushing. This is how the words that people use to describe it. Also, people will report this sense of impending doom, whatever that means to you, okay, that is associated with having a heart attack. So very, very powerful, very kind of one. If you experience this kind of pain, you need to call 911 and you need to go to the doctor immediately. In a lot of instances, angina is going to occur during exercise or some kind of activity, or when you're stressed, when cardiac output is going to get elevated, okay? You may have a significant blockage in a coronary artery at rest, but it's not going to be so much to where what normal blood flow to the heart at rest is. You can get a sufficient amount at rest, but it may only manifest itself when you make the heart work more forcefully and make it work harder to raise stroke volume and to raise heart rate, as what happens during exercise. So you'll see a lot of this will come on during exercise, or it will come on when somebody gets stressed out and their heart rate goes up, and then they stop exercising and it goes back down and it begins to go away, okay? So it may in that way be transient. That's also one of the reasons why when they think you've had a heart attack and you get to the hospital, as long as you're stable, they're going to put you on the treadmill and they're going to try to exercise you to see if they can bring on angina, to kind of figure out where and when is all of this happening. Okay, so one of the other diagnostic tools, one of the things that will tend to come on with angina, but it's a thing that you have to be hooked up to an EKG to be able to note, is lack of blood flow to the heart. While it causes pain, is also going to very often cause arrhythmias. And so you're going to have weird looking things on your EKG. You're not going to have normal atrial and ventricular depolarization and repolarization. Okay. And so one of the things that we tend to see, one of the things that is a hallmark of lack of blood flow, especially to the ventricles, is going to be something that looks like this in comparison to this on your EKG. And this is called S to T segment depression. And so in the EKG, you have this thing that denotes ventricular depolarization that is QRS, okay? And then it tends to, at S, it tends to come up, and you're going to get flat baseline, and then you're going to see ventricular repolarization in the T wave here. And so when you have cardiac ischemia, or when you have, in a lot of instances, especially left ventricular ischemia, then you get this S to T segment depression. And so you do not see the return here of the kind of post-T segment or post-S segment, excuse me, back to baseline prior to getting your T wave. And so you're still getting ventricular repolarization. So you're still getting all of the normal waves, but they just look strange. And so this is going to be indicative of ischemia. Because of the ischemia, you're going to have a more difficult time kind of transitioning into that repolarization phase. Okay, so S and T segment, or S to T segment depression, is a hallmark of cardiac ischemia. Okay. So when you put someone on the treadmill, you put them on an EKG post a heart attack, this is one of the things that we're looking to see if this happens. Okay, there are some other ones. There are some other common arrhythmias and things that are going to be associated with cardiac ischemia, but this is the primary one. It's really the one that we're going to talk about. Okay. Okay. So what I want to talk about next is what are we going to do to people that have this transient ischemia and therefore this transient angina. So we can group people that experience angina into one of two groups. Okay, people that have what we call stable angina and people that have what we call unstable angina. If you have stable angina, one, you can mostly benefit from exercise, and there are these minimal risks associated with doing it. But stable angina is going to denote people that have, I start exercising, maybe it comes on, I stop exercising, it goes away. Okay, it's very predictable, and in that way, it's quote unquote stable. We can know when it's going to happen, and because of all of that, we can try to avoid some of the higher intensity exercises that may bring it on. Okay, those people can benefit. Exercise is good for these instances. One, because it can increase the size of the blood vessels, and it can also lead to cardiac hypertrophy, both of which can help us kind of circumvent the further development of atherosclerosis and further development of cardiac death or cardiac tissue death. Unstable angina is, you may stop exercising and it may stay. Sometimes you get it when you're not exercising. It's much more unpredictable, and that makes it unstable. Okay. So in people that have unstable angina, we want to make sure that we don't have you exercise until your clinical symptoms have improved. Okay. And by improving, we mean until your unstable angina has, for the most part, turned into stable angina, that you're not getting it during times when there's not going to be additional exertion, and that is going to predictably go away when you stop with exertion. Okay, so unstable angina is much more associated with more severe impairments in cardiac conduction. That's why it can be much more dangerous. The primary goal of exercising people that have all of this is to raise what we call the ischemic threshold. We want to raise the workload at which people's angina is going to occur. So by having them exercise, we can get cardiac hypertrophy. As I said, we can get an increase in the diameter size of our coronary arteries. We can actually get sprouting of new coronary arteries, all of which are going to function to allow either more blood flow to get to the heart. And so that means you can walk at a faster rate, or you can jog at a faster rate. You can go up a steeper incline. You can do more work during exercise. Okay, the heart can do more work before we reach that threshold where it's going to become ischemic. And so that's going to be our goal. Okay, We want to make it where people can walk and get around and they're fine, that maybe they can't run super fast. Okay, so that's going to be the other big kind of things. Okay, all right, we talked about that. Let's talk about a myocardial infarction, although we've really done this in a lot of issues. So the infarct that occurs that may sometimes be associated with the ischemia. If you just get ischemia, okay, you may have angina. If you have more prolonged ischemia, then you're going to have an infarct. This is going to be the damage to the cardiac tissue. When the tissue begins to die, that is the infarct. Okay, so the degree of especially ventricular dysfunction is going to depend upon how much area of cardiac muscle has died. Okay, so one of the most common treatments for people that have had infarcts is going to be a beta blocker. And so a beta blocker is going to slow heart rate, but it's also going to kind of have these more pronounced effects on lowering blood pressure. And so if we can do all of that, it reduces the work of the heart. And so it's going to allow the heart to kind of work around that dead and damaged tissue. Okay. So very often when a person has a heart attack, what they are getting is they're having ischemia. And if that ischemia lasts for a little while, they're going to begin to get arrhythmias, they're going to have angina, and then they're also, if it lasts long enough, they're going to have this infarct. Okay. And so once we get death in the cardiac tissue, though, if we exercise and we strengthen the cardiac tissue, we can kind of have some level of repair to this dead tissue. Okay, that's the good thing about cardiac muscle, is it is very plastic and it can repair itself and it can continue to grow. So even though you get some damage, you can overcome all of that with proper things. Okay, so one of the things that happens in people that have had a myocardial infarction is they're going to have a reduced exercise capacity. Okay, they're going to have a kind of reduced capacity there because they have less cardiac muscle that can work. They're going to have a lower stroke volume. They're going to have a lower peak cardiac output, and so that means they may only be able to work out up to maybe 50 to 70% of what you would predict for a person that is that age and that particular gender. Okay, so post-infarct, your work capacity is going to be down. This is why people that are post-heart attacks have a hard time walking up and down stairs. They have a hard time carrying their groceries. Okay. And so we're going to need to retrain them. They're going to have to start off back, at square one with walking and things to try to improve themselves. Okay, so the effects of exercise. One of the big things that we can get is if you exercise people that are post heart attack, we can very much improve their outcomes. They can do it. That's kind of what's going to be on here. Okay. So people that are going to do chronic exercise after a heart attack, you've done cardiac rehab, and then you continue doing things, you can make your VO2 max go back up. Okay. A person who is immediately post a heart attack, their VO2 max may be down 50 or 60%. Right. So if you guys look at that, some of y'all have figured out what your VO2 max is. Imagine you just have a heart attack, your VO2's gone from 40 down to 20. But if we train you for a while afterwards, we slowly work back into things. You may not be able to ever get your VO2 max back to the 40 that it was before, but we can certainly make it go up. Okay, so we can lower your heart rate, we can lower your blood pressure, which can get you some relief from some of these symptoms and everything else. Okay, so as I said, exercise prevents these things from happening if you're doing it kind of as a preventative or a prophylactic measure, but it can also be a therapeutic measure where you're going to give it after the fact, and we can get you closer back to normal. Okay, so this is just going to talk about recommended exercise programs, recommended cardiac rehabilitation programs. They go in different phases, but they're going to get people that are post a heart attack, like as soon as your cardiac rhythm is stable, they're going to have you like sit up in bed. They're going to have you stand up to try to present some blood pressure change challenges. They're going to have you start walking and things in your room and up and down the hallways as soon as possible. And then they're going to move you into walking on treadmills. Here you can see We have this gentleman who's walking, and we've got our cardiac rehab person that is there. He has an EKG on. This is what's going on. We've got all the wires and things is what's on in our little pouch here that's hanging around his neck. So he's walking with an EKG. She's taking his blood pressure. She can look at his EKG readouts. And so they're monitoring him while he is exercising. And they're going to let him go longer, let him go at a higher and higher intensity, as long as his blood pressure response is stable, and as long as his EKGs look okay. All right, so we will do stroke, and then that may be the last thing that we get through today. I'm kind of forgetting if there's anything after stroke to talk about, but a stroke is like a heart attack, like an infarct, but it's in the brain. Okay. So strokes are going to be interruptions in blood flow to a particular region of your brain, okay? There are two common types of strokes. The first is what we call an ischemic stroke. The second is called a hemorrhagic, and hemorrhagic may be one of my favorite words in the entire world. Just don't ask me to spell it, please. But an ischemic stroke is going to be the result of a blood clot getting stuck in a blood vessel in the brain, likely due to the fact that you had a piece of an atherosclerotic plaque or some platelets that aggregated together, and they're going to find a place where there's been narrowing due to atherosclerosis, and they're going to get stuck. Okay, so ischemic is due to a blood clot. Because of that clot, everything distal to the clot is not going to receive oxygenated blood. Okay. In a hemorrhagic stroke, the outcome is the same. You're going to have an area of the brain that will not get oxygenated blood. But the cause of a hemorrhagic stroke, the hemorrhagic stroke is going to be the result of, okay, a burst or a tear or a break in a blood vessel. Okay. So the blood vessel tears itself open, and then blood is going to flow out of the vessel into the surrounding tissue. As it goes into the surrounding tissue, the pressure inside that tissue, it's like filling up a balloon. The pressure inside that tissue is going to go up and up and up. And when the pressure in the tissue becomes higher than systolic blood pressure, then we cannot force blood into that area anymore. And so the end result is no blood flow. But how we arrive there, excuse me, is going to be a little bit different. So ischemic strokes are more common. Okay, so having a blood clot is more common than having a burst blood vessel there. So with hemorrhagic strokes, we need to clear up a couple of things about something called an aneurysm. If you watched enough Grey's Anatomy, which maybe some of you did, so Derek Shepard was a sort of neurovascular surgeon, and he was always doing these brain surgeries to either repair aneurysms or repair drops in blood flow due to either hemorrhagic or ischemic strokes. But an aneurysm is a thing, okay? An aneurysm is a weak spot in a blood vessel. And so if you're looking for aneurysms in blood vessels, what you see is normal blood vessel runs along. At an aneurysm, you tend to get these bulging outs, okay? These ballooning outs of the vessel wall. And as it bulges and balloons out, then that area is going to be weaker. And so when you tend to get breaks or ruptures in blood vessels, they tend to happen at aneurysms, okay? So having a hemorrhagic stroke often occurs at an aneurysm, but in some medical term kinds of things, or if you watch enough TV shows, they may just say, oh, well, he had an aneurysm, okay? And what they mean really is he had a hemorrhagic stroke that occurred at an aneurysm. An aneurysm is just an anatomical structure, okay? The stroke often happens at the aneurysm, at that place, at that location, but they are two distinct kinds of things, okay? So the ischemic ones are more common. The hemorrhagic ones tend to be worse because you're going to get a raising in pressure in a much larger area in the brain than if you just get a clot in one vessel. And so when you have a hemorrhagic stroke, it often will affect a larger brain area, which means then there's going to be much more function and things that may get compromised. So here's a picture of an aneurysm. If you want to see one, okay, it looks like a little bubble that is ready if you just touch your finger onto it, that it is ready to pop, but that's what an aneurysm looks like. And so you're going to get blood into the aneurysm, and then if it raises its pressure and then it pops and it bursts, then blood's going to start pooling outside of this in the surrounding area and effectively cutting off blood flow to those large areas. Okay. The prevalence of strokes tend to go up dramatically in people once they reach the age of 60. Okay. So about every 4 minutes, a person dies in America due to a stroke. Okay. So about 130,000 Americans die every year from a stroke. So COVID has now almost killed as many people since, like February or something, as people that die from strokes every year. Okay. So about 50% of Americans have at least one risk factor for a stroke. We are, because of advances in medicine, there's about 800,000 or so strokes that occur every year. And so we are getting better at the survival rate from strokes, okay? About almost 90% of strokes are ischemic, as I said, due to these kinds of things, okay? So it's the 4th leading cause of death in the US. It tends to be an elite, even if it doesn't kill you. One of the things that strokes do is they are one of the leading causes of disability in especially older adults. So of these, say, 650,000 people that survive a stroke every year, many of them are going to have some level of either physical or mental disability or impairment due to the fact that they had the stroke. Okay, so when you have the stroke, the neurons in the brain that have not gotten enough blood flow, they may die. And what we do know is that unlike cardiac muscle, unlike skeletal muscle, unlike blood flow or blood vessels, unlike even peripheral nervous system tissue, that neurons in both the brain and in the spinal cord, when you get neuron death, it's very, very difficult to get any kind of regrowth. Once the neuron is dead, that neuron's not coming back, okay? So we have this very, very short window of time to be able to restore blood flow to those areas of the brain before we're going to get impairments in things. There's been a big movement of something on how to spot a stroke and how to diagnose that a person is having one, and then trying to get them to the hospital to get treatment. If you drive up and down Interstate 40 in Oklahoma, anywhere, you're going to see things on billboards talking about FAST, okay? That if a person has face drooping, arm weakness, or difficulty with speech, all of a sudden, they may be having a stroke, and that we need to call 911 and get them some help as quickly as possible, okay? All of a sudden, overcome with sleepiness, okay? So we've talked about most of all of this. One of the big things that happens with strokes when you're going to get impairments and neuron death in the brain, you're going to get diminished motor function, so people have a hard time moving. You may get decreased sensation in your extremities, and so you may lose like the feel of touch in those extremities, and that may make function of your hands or that limb more difficult. Because of impairments in motor function, people have gait abnormalities, and so it becomes more difficult for them to walk. They're also going to have decreased strength. Depending upon where it is in the brain, you may have speech impediments, you may have impaired vision, you may have impaired memory, okay? So you can see in this person in the MRI that they have here that this kind of black area here, this person had a very, very large amount of impairments in flow in their brain. And so this is a large area of the brain where they potentially may have either had some swelling or had some decreases in flow. Okay, so that one could be, depending upon how quickly they got this fixed, that could lead to very, very massive neuron damage in the brain. And so strokes tend to occur on one side of the brain. And so if I have impairments in something on my right side, on this side over here, then that means that the stroke happened on the left side of my brain and vice versa. So that's one of the other deals, that if a person has like face droop on one side, or they're beginning to lose function on one side, but they're okay on the other, that's also kind of why this bilateral, or this kind of unilateral deficit is going to be one of our hallmark signs that a stroke is occurring. Okay, so one of the risk factors of strokes are many of the same risk factors for coronary artery disease. Strokes often occur in people that have high levels of atherosclerosis in their cerebral arteries, lots of branching in the cerebral arteries, lots of relatively high pressure in the cerebral arteries. Okay, so if you take people that are post-stroke, you can exercise them and you can see some improvements in their outcomes. You can help make their aerobic fitness go up. You can help make their walking speed go up. You can improve their gait. You can lower their blood pressure. You can improve some of their risk factors. So one of the other things is, if you've had one stroke, you are very, very likely going to have another stroke. And so if we can do things post-stroke to improve your lipid profiles, to improve body composition, to improve your blood pressure, that are going to lower your risk of having a second stroke, then that's going to be really, really good for us. Okay. So the last thing to talk about today is high blood pressure. It is often referred to as the silent killer. And what tends to happen is that having high blood pressure does not often have symptoms, right? You don't have actual symptoms of high blood pressure until you're going to have a heart attack, or until you're going to have a stroke, okay? Now, sometimes you may have severe headaches. You may have vision problems. You may feel fatigue or chest pain or something like that. Occasionally, you may see, because of high blood pressure, you may see blood in your urine. You may see difficulty breathing. But very often, there's nothing going on, right? You can have high blood pressure, and if you don't go to the doctor regularly and get it checked, you may never know, right? And having high blood pressure is often going to indicate that you already have coronary artery disease, okay? And if you've already got coronary artery disease, having high blood pressure can then lead to further coronary artery disease. So it's going to exacerbate the effects of all of these things, okay? So they keep changing kind of what the stages and the levels of hypertension are going to be, okay? But here we have systolic pressure on the y-axis and diastolic pressure on the right. And so generally, anybody over a systolic pressure of 120, then you're either going to be pre-hypertensive, or you're going to be one of the various stages of hypertension. And so pre-hypertension, these people that are between 121 and 139 systolically, are going to be at a significantly increased risk of becoming hypertensive going on, okay? Similarly, with your diastolic, we do tend to see people that have much higher systolic pressures than diastolic pressures. Although in some ways, elevated diastolic pressures, if you have kind of more diastolic hypertension, can actually be even more dangerous than some of the systolic stuff. And so the stage that you are in is going to affect how we try to treat it, whether we want to give you a medication to lower your blood pressure, whether we're going to try to treat it with diet and exercise. It's just going to depend upon how prevalent it is, or how severe it is. This slide shows the prevalence of hypertension by age group, okay? The prevalence by age group. And what I want you guys to look at is that it's not until you're in your 50s or really into your 60s that we begin to see a large number of people that are going to, of the population that are going to be hypertensive, okay? And so it's very, very rare for us to find college age and young adult individuals that are going to be hypertensive. But by the time you're in your 60s, about 1 out of every 2 people is going to be hypertensive. By the time we get into your 70s, almost 2/3 of everybody is going to be hypertensive. And so again, this highlights that the development, you're hypertensive very likely because of the development of atherosclerosis. And so this is going to tell us that it takes a long time for this to happen, which is one good because you got a long time to wait before it's going to occur, but it also tells us that we've got a long time that we can intervene with exercise or with diet changes to try to prevent the development of all of this. Okay, so we don't really fully understand why some people become hypertensive. It's going to vary, but a lot of hypertension is called essential hypertension, which means it has no real, true, discernible cause. We know it's related to obesity. We know it's related to age. We know it's related to physical activity levels. We know it's related to atherosclerosis. It's also related to salt intake and kidney function. Your kidneys, I don't know how much of this you guys talked about in human phys, but your kidneys also play a very, very, very large role in controlling your blood pressure, okay? By changing filtration rate and changing the amount of plasma from your blood that's going to either be retained or excreted as urine, you can alter blood volume and you can have some pretty significant effects on blood pressure. Okay, so people that if you have chronically high blood pressure, you're going to have kidney damage and kidney issues, but also if you have impairments in kidney function, then it may also then cause high blood pressure. Okay, salt intake matters for some people. If you eat a lot of salt, then you have high levels of salt or sodium in your blood, which means you're going to retain more water in your blood. You're going to have higher plasma levels, and that's going to lead to an expanded blood volume. So one of the first treatments for people that are pre-hypertensive and kind of early stage 1 hypertensive is to stop eating so much salt. Stop eating potato chips, okay? But we really, in some people, we do not fully understand sort of what all's going on, okay? So looking at some of these things, we've talked about a lot of these kinds of things. Exercise is a very effective treatment for hypertension. If you're hypertensive, we can expect when you start exercising or increasing your physical activity as much as a 10 millimeter reduction in both systolic and diastolic blood pressure. Okay, this is likely due to exercising being a stress reliever and decreasing sympathetic nervous system output. So that's gonna lower some vasoconstriction at rest. Okay, it also exercise is going to lead to widening of arteries. Your arteries are going to get bigger. Their diameter is going to get bigger, so that's going to lower pressure going through them. For hypertension, we tend to see the best effects with aerobic type exercise. Resistance training is not as good. You don't get the same vascular remodeling with resistance training. And so, although we don't totally understand, it's not as effective at treating high blood pressure. Okay. Okay. So if you're trying to exercise people that are super high blood pressure, you just got to pay attention. Okay. Having too high of a pressure response during exercise because the person started off with a high blood pressure can be very, very dangerous. Okay. You're going to want to kind of reduce exercise intensity in those people. You guys will talk about this much more so in exercise testing and prescription if you want to. Okay, so there's a little bit of recommendations. The recommendations for exercising a person that has cardiovascular disease are mostly the same as a regular person. It's just start them off at a little bit lower of intensity. And if they begin to experience angina or arrhythmias during exercise, then stop. Okay. Take home message, pretty simple from all of that. Okay. So
Dr. Buck,
yes,
I have a question.
absolutely. Please fire away, Madison.
So what would you call like a mini stroke? Like something that's not as bad. Like someone I know had one, but
They
it
said that
wasn't
they had,
like a full stroke.
they call it a TIA or something like that. They had a transient ischemic, what does the hell does the A stand for? It should be like a transient ischemic event. So it should be like a TIE. My grandmother had multiple strokes, but they had like these little mini strokes where the person just kind of like looks at you and sort of blinks and they're like out for just a couple of seconds. Or did your person have something that was more than that, but it was not like a full on massive stroke?
I wasn't there when she had it, but I just remember her saying something about being like really, really like stressed out, like almost having a panic attack.
Mm-hmm.
And it was my mom, and
Okay.
she like begged my brother to take her to the hospital.
Yeah, sure, which is absolutely the right thing to do. So TIA, the A stands for attack. So it's a transient ischemic attack. And those things can be a few seconds, they can be, maybe a minute or two, but it's one of those things where you get this transient interruption in blood flow. And if you're lacking blood flow in certain areas in the brain, depending upon what those areas are, it may not be enough to cause permanent damage, but it can be something that can be very, very scary and, very stressful in that way. So I just looked them up. I'm looking on my phone. I'm seeing what the Mayo Clinic has to tell us about things. Often called a mini stroke. About 1 in 3 people who have one of those will eventually have a stroke, with about half occurring within a year of their TIAs. They usually only last a few minutes. So they often are accompanied by like vertigo and loss of balance. So I'm looking, they say, yes, you should obviously go to see all of those. And what may be happening is that you have a blood clot or a clot that moves through and it gets stuck and then it gets released or something, as a part of all of that. So, but it looks like the risk factors for those are basically the same as the risk factors for kind of more of a full-on stroke. So really scary. I hope your mom is okay after all of that medicine. So anyway, okay. Are there other questions? No?
I know
Okay.
this was probably covered, but you want our calculation for our VO2 through email? Or
Yes. So
okay.
please send me by the end of today. I've gotten it from a few of you guys. Please send me the distance you covered in your 6-minute walk. It can be in either meters or it can be in like, tenths of your tenths of a mile thing. Send me the distance covered. Send me your resting heart rate. And then please also send me the VO2 max that you've calculated for yourself using the estimation equation that's provided in the lab. Okay. And so I'm going to aggregate all of those together into an Excel sheet. And then I will denote men and women, and then those variables, and then I will provide those to everybody hopefully this evening. Okay. All right. Very good. Okay. So if there are no more questions, then you guys have a wonderful rest of your Wednesday, and I will see you tomorrow as we talk about diabetes.